As many of you have probably seen in the press, there is an increasing number of patients who present to hospital during the summer months with hyperthermia and heat stroke. The increase in the temperature of the planet has resulted in increasing temperatures during the summer, and there's therefore been an increase in the number of people who are presenting to hospital as a consequence of the increased heat. So it's important that you understand what heat stroke is and its relationship to hyperthermia. Now, heat stroke itself is fairly simple. It's simply a syndrome diagnosis marked by an end organ dysfunction that is occurring as a result of hyperthermia. Hyperthermia is defined as any temperature greater than 41 degrees Celsius, and it's caused primarily anytime you have a problem of heat generation that's exceeding your ability to dissipate it. So either you're producing more heat than can be gotten rid of, or there's something in the environment that's impairing your ability to get rid of the normal metabolic heat that you normally produce. We break up the causes of hyperthermia into two categories, those that are exertional and then those that are non-exertional. Exertional causes are fairly straightforward. Those are the people who who will be exposed to environmental causes such as increased temperature and humidity, and then there's also those who have what's called physiological exertional heat hyperthermia, and these are people who are working in a hot environment, overexerting themselves, may not have had time to acclimatize properly, or generally are deconditioned. So somebody who is now working out on outside, has never worked outside before, and is wearing a lot of protective gear may find themselves suffering from a physiological hyperthermia. Non-exertional causes are a little bit different, though. You get these can be caused from a variety of different things, such as environmental problems, such as the high humidity, high temperature, exposed to an inability to cool yourself because you're either in an environment where you don't have access to air conditioning, or you're at a higher altitude in an apartment building. So the people who presented in the summer in the past have frequently been apartment dwellers who didn't have access to AC, and even though they weren't exerting themselves, the high humidity, high temperatures, and an inability to cool caused them to develop hyperthermia. There's also a number of physiological causes that can impact on your ability to dissipate your heat. People who are over the age of 65 are at higher risk, as well as alcoholism and a number of different chronic medical conditions such as congestive heart failure, renal failure, and diabetes all impair your ability to dissipate your heat. Most of these patients, as you can imagine, are also under the influence of medications, and alcohol and other drugs can have a significant impact on your ability to dissipate heat, and may actually cause you to retain heat abnormally. Particularly people who are taking anti-dopaminergics or anticholinergics are particularly prone to having an inability to dissipate their heat because of the vasoconstriction that occurs. Anticholinergics reduce your ability to sweat, and anti-dopaminergics reduce your ability to dilate and dissipate the heat. And then finally, either licit or illicit medications that are stimulants can increase your heat production, and in an environment of increasing heat, you may actually find yourself unable to dissipate all of this heat. So while the treatment of heat stroke is usually fairly straightforward, identifying it is more of the challenge. Now, exertional heat stroke is usually pretty obvious. I mean, these people come in, there's a history of them exerting themselves. They've either been exercising or they've been working in a hot environment, wearing protective gear, and they're hyperthermic, and it's usually pretty clear what's going on with them. It's those people who present with non-exertional causes that you really need to watch out for. The presentation may be much more insidious. Their clinical presentation starts low and then gets initially they can get quite sick. So, for example, people will initially present with just generalized irritability, but as the temperature, their body temperature increases, they become stuporous and then eventually comatose. The other problem is that this is frequently mistaken for sepsis. I mean, they have a temperature, they're irritable, they have evidence of end organ dysfunction. I mean, that would be the first guess you would have. So you really need to dig into the environmental clues and look for those risk factors, such as medications and the environment that they're living in, to try to identify whether or not they're hyperthermic and in heat stroke. So the classic presentation would be the elderly lady who lives alone in an apartment at a higher altitude or a higher floor, who is taking a number of anticholinergics and doesn't have air conditioning. They're found with a decreasing level of consciousness and their body temperature is high, and they're initially thought that they might have a urinary tract infection and sepsis because their temperature is elevated, the urine is concentrated, and they're confused, when in fact the whole problem all along is that they're actually in heat stroke. So when you are looking at the patient, really consider when you're in that time of the year where people are at risk for developing heat stroke, make sure you ask yourself the question and dig around a little bit more into the environment and consider not just the possibility of exertional, but non-exertional heat stroke as a possibility. Looking then also for chronic diseases, elderly patients, and the use of a number of different medications that will blunt their ability to thermoregulate as clues to what's actually going on. Now, in the past, people have said that if you lose your sweat reflex, this is an indication that you're going from hyperthermia into heat stroke. When in fact, that loss of the sweat reflex is not really a consistent finding, and you really can't use that as a clue to whether or not the person has actually gone into heat stroke. As the condition progresses, they start to develop a number of late-stage changes, including they'll start having seizures, they develop rhabdomyolysis, there's actual hepatocellular injury that goes on, in addition to all of the free water and electrolyte disorders that you would normally expect to somebody who's has probably sweated excessively and is now both volume depleted and has lost a lot of their salt. So a lot of people who are unconditioned and exerting themselves will, as they when they sweat, they lose a sweat that's much more isotonic. Athletes who work in hot environments on a regular basis develop an acclimatization where they retain their sodium and chloride, and they tend to lose just free water. So you need to understand that there are a number of different free water electrolyte disorders that can occur. A marathon runner who's well conditioned will probably be hypernatremic because they've lost their free water. Whereas a first-time marathon runner may just be volume depleted, but isotonic because they've lost isotonic sweat. So the management of hyperthermia is fairly straightforward. First and foremost, cool them. Cool them by whatever method you like. Evaporative techniques are usually pretty effective. Or you can, if they're awake enough, you can just use cold water immersion as the technique. You need to watch out for volume depletion. You need to restore their intravascular volume first and foremost. They can develop some myocardial dysfunction, and so rapid changes in their temperature can cause a significant amount of myocardial stress. You also then need to treat and address any underlying end organ dysfunctions, particularly renal injury as a result of the rhabdo, hyperkalemia from the rhabdo, and if they are having seizures, you would just treat them as you normally would treat for any other patient with seizures. So most of the management of hyperthermia is relatively straightforward. You cool them off, you give them fluids, and then you deal with the consequences of the end organ dysfunction that may have manifested from the stress injury. So that's all there is for today. If you have any questions or comments, please feel free to leave them in the comment section below or you can contact me directly. Thanks for watching.